So the issue that we see in the clinic today when it comes to multiple conditions that have an interplay is really, especially when it comes to dry eye and myopia control, dry eye puts kids at a disadvantage for success with myopia control therapies. I mean, today kids, because of screen time and so device use, environmental exposures, I mean, even the air is more polluted than it used to be. So we do see children that present at younger ages with meibomian gland loss. They have allergy because of their environment. And so when we try to put them into a myopia control therapy like a contact lens or use an eye drop like atropine, it can really be harder for them to be successful. In fact, I would say that one of the number one failures that we see, it's not fitting kids into myopia management strategies. It's when it comes to solutions, handling, comfort. Those are all things that play a huge role. And those are all things that dry eye kind of acts against. It's almost like the perfect storm when it comes to dry eye and myopia control, because those are two separate entities that when they come together, which they do, it just really creates a situation that's just not good for the kids. So when it comes to our children harder to handle or manage in a dry eye environment or with myopia control, I would say not because of their age. Honestly, patients of all ages can be difficult to communicate with at times. And so I would say the greater challenge actually lies with practitioners being afraid to treat dry eye in kids or not remembering to. You know, we have lineups out the door for myopia control with children and often we'll jump right into therapies without even looking at the lids and lashes to see if they've got underlying inflammatory conditions that could harm their ability to wear a contact lens, for example. And so I think the greater barrier, greater than communication with the patient themselves, because they can be very plastic. Kids are very coachable. Kids are very trainable. Often parents can be a great asset on the team to really supervise and make sure that the things that we ask kids to do are actually being done. The greater barrier comes to practitioner comfort of comfortably considering dry eye therapies that traditionally we would reserve for adults and to actually apply that into the pediatric clinic. That's a greater challenge that I see.